So fibula is present in which section of our body? Leg. Lateral side of leg, and it is homologous with which bone? Ulna. So basically ulna is present medially or laterally? Medially. And tibia? Tibia is laterally, okay. So basically, as we all know that in our lower limb, the front part is known as extensors. Extensor is the front part of the leg. You all know, na? So the back side of the leg is known as flexor region, okay. So basically, what we can see, if this is our hand, and as we have already discussed that during our embryology period or fetal life, it rotates like this. So this part is dorsum of our hand, this part. But in case of foot, the opposite thing, the upper part of the foot is known as the dorsum. Okay. So basically, the part that we usually see in our foot is the dorsum, and the sole is known as plantar region. Okay, and this part is the flexor region in case of our foot. So this part is flexor, this part is extensor, and in front we have the dorsum of the foot, and below we have the plantar region. That is why this movement of our foot is known as dorsiflexion. Okay, and this movement plantar flexion. So do you know any nerve injury that causes, disturbance of dorsiflexion associated with fibula? So common peroneal nerve, we will see, okay. So fibula is the lateral long bone of the leg, homologous with the ulna of upper limb. So how to determine the side? So this is right sided or left sided fibula? You cannot appreciate, na? So basically, see, this is the lateral malleolus. As the name says, it will always present laterally. So first of all, we need to know the lateral malleolus, which is present laterally. Then we need to see the styloid process, which should be posterolaterally to the head. So this is the styloid process. This sharp projection is the styloid process. So this should face posteriorly and laterally. Okay, posteriorly and laterally. So is it facing posterolaterally? So it is not facing posterolaterally. This is posterolateral. Okay, so if you hold the bone like this is posterolateral to your side. Okay, so this is right sided fibula. For me, this is my posterolateral, so this is my right fibula. Okay, then we need to see the anterior border as well as the interosseous border. So the fibula is actually a very complicated bone in the sense that you need to have some imagination of the structures, borders and surfaces, like you need to know what is medial, what is lateral. For example, this is the medial surface, then automatically question comes, sir, this is also the medial surface, but no, this is the posterior surface, medial part. So that is why the fibula is actually a tough bone for exam purpose also. So see, this styloid process is present posterolaterally, and in the lower part we have the lateral malleolus facing laterally, and in front we have this anterior border and interosseous border which are facing in front, and in the lower part we also have the triangular area just above the styloid process. See, this is the right fibula, the lateral malleolus facing laterally, and here is the styloid process present in the head. Then comes the anterior border, then just adjacent to this comes the interosseous border. In the upper part of the two borders, the surface is very narrow, almost 3 to 4 millimeter gap. See, in this bone also you cannot appreciate. This line, this border is the anterior border. You understand borders and surfaces, na? So give me a copy. So which part is the border and which part is the surface? This is surface or border? This is surface. Okay, these are the borders. So similarly, in a bone, these sharp parts are the borders. Okay, and in between two border we are having the surfaces. Okay, so see, in this bone, this is the lateral malleolus, this is the anterior border. This is the anterior border, not this whole part, just this part is the anterior border going downward like this, forming a triangular like structure here, a triangle like structure here, and joining with the lateral malleolus. This is the anterior border. Just adjacent to the anterior border, we are having the interosseous border going downwards like this and joining with the just above the this facet for talus. See, so in the lower part you can differentiate the interosseous border from the anterior border, but in the upper part it gets, I mean, adjacent to each other. And so this is the posterior border. See, this S-shaped border is the posterior border going downwards like this, because adjacent to the posterior border is also another such structure, that is the medial crest, which divides the posterior surface into medial and lateral. Okay, so in this figure you can appreciate properly, this is the anterior border and the interosseous border, and this is the posterior surface, and the posterior border here, see the small posterior border going downwards like this, forming an S-like structure, and then again coming downwards like this. This is the posterior border. Okay, you are getting na? Okay, so in between the anterior border and the interosseous border we are having what surface? Anterior border and interosseous border, this surface, medial surface. Why not anterior surface? Because the bone is present like this. So this surface is facing medially, not anteriorly actually. It seems like it is facing anteriorly, but no, it is facing a bit medially. So this is the medial surface. Similarly, this is the lateral surface. Okay, and just posteriorly we are having the posterior surface, which is the main surface of the whole fibula. So this is the medial surface, this is the medial surface, this one is the lateral surface, and posteriorly we are having the posterior surface divided by the medial crest into medial posterior surface and lateral posterior surface. So the fibula has three parts: upper end, shaft and lower end. Okay, Anurag. So the fibula has three parts: upper end, shaft and lower end. And the upper end has the posteriorly and laterally, posterior laterally we are having the styloid process, and just anteromedially or in front and medial same thing, anteromedially to the styloid process has articulation for tibia. See, this is the articulation for tibia, this part. Tibia is present above it, no, like this. You have seen tibia na? So the bone is present like this, then anteriorly you are having the tibial tuberosity. Okay, so the tibial facet, this is the tibial facet in the fibula for tibia bone attachment. Here also we will see one capsule. So in the shaft is again divided into three borders and three surfaces, as I have already told. The three borders are anterior, posterior and interosseous. So what do you mean by interosseous? In between two bones. So any membrane present there? Interosseous membrane. So in our upper limb we have seen that the interosseous membrane is present between radius and ulna. So was it covered in the whole segment, like the whole interosseous part was covered in the interosseous membrane? No, around 3/4 was covered. Some place was left for the passage of vessels and nerves. Similarly, in the lower limb also around 3/4 will be covered by the interosseous membrane, and a small segment in the upper part will be left for the passage of anterior tibial vessels as well as nerve. Okay. So the three surfaces are lateral, medial and posterior, and the lower end is flat, and laterally we are having the lateral malleolus. Just medial side of the malleolus, it bears a triangular articular surface for the talus. Talus is part of foot. Okay. And deep malleolar fossa is present just behind the articular surface. So this is the facet for talus. See, this is the facet for talus. So the talus bone attaches here and form the ankle joint. Okay, and just behind it, see, this fossa, this is the deep malleolar fossa. Okay, this fossa is the deep malleolar fossa. Now the shaft has three borders. Anterior border is sharp, begins below the anterior aspect of head. Near its lower end, it turns laterally and joins the apex of the triangular area above the lateral malleolus. This part, this triangular area. This is the anterior border going downwards and forming the triangular area just above the lateral malleolus. Then the posterior border, its upper end lies in line with the styloid process. See, here the styloid process, from the styloid process the posterior border is coming downwards and just making a curve and going downwards like this. Okay, this is the posterior border. In the posterior border itself, the surface is divided again into this medial crest into medial side and lateral side. Now the lower end reaches the medial part of the posterior surface of lateral malleolus. So lateral malleolus, posterior surface, medial part. See, the posterior border is coming like this, is forming a S-shaped pattern. Then the interosseous border lies near anterior border, merges with the upper part of the rough area above the talar facet of the lateral malleolus, as I have already shown you. Now the surfaces. So the lateral surface is forming between anterior and posterior surface, and the medial surface is formed between anterior interosseous border, anterior and posterior border, and anterior and interosseous border, and the posterior surface is formed between, yes. So the lateral surface between anterior and posterior borders, it faces backward and continues with posterior aspect of the lateral malleolus. Medial surface, it is present between anterior and interosseous borders. It is very narrow in the upper half of the shaft. Its lower broader part faces as much forwards as medially, as I have already told. This part is the medial surface, but it faces almost anteriorly. Now the posterior surface is present between interosseous and posterior borders. It occupies larger area of the shaft. Upper 3/4 is divided into medial and lateral part by a vertical ridge called the medial crest. See, this vertical ridge. Ridge you know na, elevation. Okay. So this is the vertical ridge, this one. This is dividing the posterior surface into medial and lateral part. So now coming to the muscle attachments. So basically how many muscles are there in the fibula attached here? Anyone, any idea? 9 muscles. Okay, 9 muscles. So only one muscle has inserted in the fibula, and all the other 8 muscles will have their origin from fibula. Okay, so the biceps femoris is the muscle which originates, inserts in the fibula head, almost in the styloid process. And this is the capsule of the tibiofibular joint, which we will discuss. And please don't talk. Pritam, don't talk. So this is the biceps femoris insertion. Then this part is the, okay, so the muscles originates from the surfaces, medial surface, lateral surface and posterior surface. In the medial surface, in the upper almost, total you take it as 3/4 part, it is having origin of extensor digitorum longus, this red muscle. This is the extensor digitorum longus, and just in the lower part we are having the peroneus tertius, and then this green muscle is the extensor hallucis longus. So these are the muscles originating from the medial surface. Okay, extensor digitorum longus, extensor hallucis longus and peroneus tertius. In the lateral surface we are having origin or peroneus longus and peroneus brevis. So what do you mean by peroneus? Peroneus means pin-like structure. So this peroneus muscle you will see in the cadaver also. These are very thin muscles. Okay, thin but long. So peroneus longus is the long muscle. Then brevis is a comparatively a small muscle than the longus. So this is the peroneus brevis. And in the posterior side we are having the soleus, tibialis posterior and flexor hallucis longus. Okay, this medial crest divides the posterior surface. So laterally, in the lateral part of the posterior surface, here is the soleus origin, and in the lower part, in the same lateral part of the posterior surface, flexor hallucis longus has its origin, and in the medial part, tibialis posterior. In the cadaver you can appreciate this structure properly in the coming weeks. So lower limb will start, and in the leg you can appreciate these structures. So Now the attachments. So biceps femoris, insertion in head of the fibula, extensor digitorum longus, origin from upper 3/4 of the medial surface. See this one. Then peroneus tertius, origin from medial surface below that for the extensor digitorum longus. Extensor hallucis longus, origin from medial 2/4 of the medial surface, medial to the origin of the extensor digitorum longus, just adjacent to this part. If the red muscle is occupying almost 3/4 of the fibula, then the 2/4 is occupied by the extensor hallucis longus. Then peroneus longus, present laterally, origin from the upper 2/3 of the lateral surface and lateral aspect of head of fibula. Peroneus brevis, origin from lower 2/3 of the lateral surface. Then tibialis posterior, origin from upper 2/3 of the medial part of the posterior surface. Soleus from same origin from posterior aspect of head and from upper 1/4 of the lateral part of the posterior surface. Flexor hallucis longus, origin from lower 2/3 of lateral part of the posterior surface. So these tables look scary, na? So for this reason, you need to, in your workbooks, you need to, or in your copies, you need to draw the bones and make the muscles like this. Okay. So if you draw the muscles like this, then you don't need to memorize this. You can easily see that if this is the fibula, what portion is being taken by the peroneus longus muscle. See the lateral surface, almost half, more than half is taken by the peroneus longus muscle. So you can easily say that the lateral half of the fibula is have origin for peroneus longus, and just below the peroneus longus there is origin for peroneus brevis. Only biceps femoris has insertion. I mean origin is somewhere else, inserted in fibula, and all the other muscles have origin from here. So there are some other attachments in the fibula. Capsule of the superior tibiofibular joint. See, this capsule is present here, almost in the head. This is this facet. So here the tibia attaches, the right tibia attaches. So due to this, around the capsule, around the bone, there will be a capsule. Capsule for what purpose? Huh? No, to prevent friction. Okay, or else the two bones will undergo friction. So there will be, erosions of the bone. Okay. Then fibular collateral ligament, present on the lateral aspect of the head. If this is the head, almost in the lateral aspect, this part we are having the fibular collateral ligament. See the fibular collateral ligament. Always see the lateral malleolus. This is the lateral side. So then almost lateral to the head, this is the head. Lateral to it, we are having the fibular collateral ligament. Then interosseous membrane, present in the interosseous border, obviously, and interosseous ligament of the inferior tibiofibular joint is present just at the triangular area above the malleolar articular surface. So this is the triangular area where the interosseous ligament of inferior tibiofibular joint is present. So basically here the lower part of the fibula joints. So what is this joint called? Tibiofibular joint. What type of joint?
Knee joint.
No, this is not knee joint. Pivot joint. Okay. So the posterior tibiofibular and posterior talofibular ligaments are present at the malleolar fossa. So this is the malleolar fossa. So posterior at the malleolar fossa, posteriorly we are having the ligaments for tibiofibular joint as well as the talofibular joint. So talofibular means the talus also forms a joint with the fibula to form the ankle joint. Okay. So surrounding that there is a ligament which is present at the malleolar fossa. Now coming to the superior extensor retinaculum of the ankle. So superior extensor retinaculum will be present anteriorly or posteriorly? Anteriorly. So superior peroneal retinaculum will be present posteriorly. So superior extensor retinaculum of the ankle is present at the anterior border of the triangular area above the lateral malleolus, and superior peroneal retinaculum will be present on the posterior margin of the lateral malleolus. That's all. So see, just behind the lateral malleolus we have the tendons of peroneus longus and peroneus brevis. So peroneus longus is originating from Peroneus longus originating from lateral surface of fibula. You are getting na? So this is the peroneus longus muscle. It will be having a tendon. All the muscles have tendon. So it passes posteriorly to the lateral malleolus. Similarly, peroneus brevis tendon also passes posteriorly to the lateral malleolus. Any other structure left? See the common peroneal nerve at the neck of the fibula. So, fibula, some other relations. The common peroneal nerve winds around the lateral aspect of the neck of the fibula, and tendons of peroneus longus and brevis, as we have already seen, pass just behind the lateral malleolus. So, common peroneal nerve, any other name you know for this nerve? So, the bone is fibula. So, this nerve is also known as common fibular nerve. Okay. Common peroneal nerve divided into superficial and deep nerve. Superficial peroneal nerve and deep peroneal nerve. Why this nerve is important? Due to two reasons. One thing is you can easily palpate this nerve on your knee, just adjacent to your knee. Okay. And second thing is any fracture of the knee, if the fibula neck gets injured or fractured, so the patient will not be able to do dorsiflexion. So there will be foot drop. The foot will drop like this. How to confirm foot drop? If you suppose these are the toes of a patient. If the patient is asked to like walk on their toes like this foot which is injured will fall like this. So dorsiflexion will not be supported properly. This is dorsiflexion na. So this will fall like this. So the fibula, now ossification part. The fibula has three centers of ossification. The primary center usually begins at the shaft and gets completed in the 8th intrauterine life or 8th fetal week. Fetal week and intrauterine life difference? Intrauterine and fetal? No, that is infant or newborn. So fetal life is also same as intrauterine life. Okay. Now the secondary centers, there are two secondary centers, one at the upper end, another one at the lower end. Okay. So basically the upper end, it appears at the 3rd or 4th year and fuses with the shaft between 17 and 19 years. And secondary center for the lower end appears in the 1st year and fuses with the shaft between 15 and 17 years. So there is a catch, is that basically in any bone, if the secondary center appears earlier than another secondary center, it will fuse later. Okay. Suppose two centers, this center has the secondary center appeared earlier and this has their secondary center appeared later on. So these will fuse first and these will fuse later on. But in case of fibula, the secondary center for the lower end appeared first as well as fused earlier. Okay. So in most long bones, the secondary center that appears first is the last to fuse. The fibula is an exception in that the center which appears first for the lower end is also the first to fuse. Now coming to clinical anatomy, so the first two parts has been discussed. Now coming to bone grafts, since fibula, what do you mean by fibula? Fibula is also a pin-like structure. Fibula in Greek means pin. Okay. So pin-like bone. So this bone is usually taken for grafting purpose. Suppose there is a fracture of an important bone, for grafting purpose the fibula is taken out. Okay. Potts fracture is actually a comminuted fracture. It is like a mixture of fracture. In this fracture you will see that the lower end of the fibula is broken, the medial malleolus of tibia is broken, as well as the deltoid ligament is also torn apart. So that's all in fibula. This is patella. Patella is also known as kneecap. Kneecap. Okay. You have seen any kneecaps? Artificial kneecaps? Not artificial, like in any sports. You have seen kneecaps, na? So in cricket, kneecaps are used mainly. So basically, patella is a what type of bone? Sesamoid bone. So what do you mean by sesamoid? No.
So So that the bone that is present on there is
Glide over the other bony surfaces. So sesamoid bones are formed in the tendons of other bones, other muscles, so that the muscles can easily glide over the bony surfaces. Okay. So the tendons of some muscles have embedded in them small bones that help them to glide over bony surfaces. Such bones are called sesamoid bones. So patella is developed from which bone? Which muscle? Quadriceps femoris. Okay. So quadriceps femoris is a very vast muscle, long muscle. So long as well as broad muscle, as you can already understand from the name itself. So this muscle is present in which part of our leg? Thigh. Why thigh? From the name itself you can see that it is femoris. So it will be present in the femur, anterior aspect. And then quadriceps means 4 heads. Okay. Triceps means 3 head, biceps means 2 head, quadriceps means 4 head. Now side determination. So usually how to point an apex? Apex means what? Upward, but in case of patella it is downwards. So this is the apex. Okay. So this is the apex, and this one is the base. This upper part is the base. So the apex will always point downwards, and the anterior surface will be non-articular. So you can see now in your knee also, that part is very much rough and tough. So this is because the patella is present absolutely in front now. So and this is non-articular also, like no bones articulates here in the anterior part. So it is free. That is why we can easily palpate the patella. So this is the anterior surface which will be rough and non-articular. Posterior surface will be smooth, at least on the upper part. And in the posterior surface there will be a lateral surface and a medial surface. How to differentiate the lateral from the medial? No, in both the bones, the medial and lateral definition will change, na? So how to know like which one is the medial side? If a bone is given like this, I too cannot understand which one is medial, which one is lateral. Obviously, we can understand from the apex itself. One point is this. Second point is the medial surface will be smaller one, and the lateral surface will be larger one. Okay. So in this way, we can know that suppose this is a bone of the right leg. Okay. Now from this bone, see here the medial surface is in this part. So if I don't know that whether it is right leg or left leg, see if I don't know whether it is right leg or left leg, see this one is the medial, this part also seems medial, but from the surface area we can see that this is a larger surface area. So this is lateral surface. Here we can see that this one is the larger surface area, so this one is the lateral surface. So this is bone of our left leg and this is patella of our right leg. Okay. So the apex directed downwards, anterior surface rough and non-articular, posterior surface upper 3/4 smooth and articular. Posterior articular surface is divided into lateral larger and medial small areas by a vertical ridge. So again, just adjacent to the medial surface also, you can appreciate another small medial surface. Most medial surface. See, this part is the medial surface. Just adjacent to this, you are seeing one depression like structure. Now, this is the most medial surface. Like the whole medial surface, and this one is the most medial surface. So what happens in extreme flexion of our knee, the condyles of the femur usually attaches here. Okay, we will see also. And this, this surface areas is divided by a vertical ridge. This one is the ridge. This one is the elevated ridge. See, this is the anterior surface, this is apex, and this is the superior, base. This is the posterior surface. The upper 3/4 is articular as well as smooth. This is the lateral surface. This is the medial surface. From this picture, you may think that this is the larger part, but actually this is the smaller part. This is the larger part. So this is the larger lateral part, and this is the smaller medial part, which is again have a most medial surface. So now the patella is a disc-shaped bone, triangular in outline, two surfaces, anterior, posterior, separated by 3 borders: superior, medial, and lateral. Okay. See, This is the superior border. This border is the superior. This border is the superior border. And this is the medial side, so this is the medial border. And this is the lateral border. So superior border, medial border, lateral border, dividing the patella into anterior surface and posterior surface. Okay. Now the anterior surface, same thing, rough and can be felt through the overlying skin. Posterior surface, upper part is articular. So the articular part, see, these parts, these are the articular parts. It articulates with what bones? Femur. So you have gone through the condyles of femur. I mean the femur has been covered now. So femur has one medial condyle and one lateral condyle. So the medial condyle articulates with the medial surface of the patella, medial posterior surface of the patella, and the lateral condyle of the femur articulates with the lateral posterior surface of the patella. So this forms the knee joint mainly. So the posterior surface, upper part is articular, it articulates with the patellar surface on the anterior aspect of the condyles of the femur. The you know now what is anterior aspect of the condyles. So basically, if this is the femur, if these are the condyles, this anterior, suppose this is the condyle, suppose medial condyle, only medial condyle. So it will have a anterior aspect and a posterior aspect. So if the patella is present like this, forms articulation like this, so the anterior aspect of the condyle has been covered now. So that is what it is saying, that it articulates with the patellar surface on the anterior aspect of the condyles of the femur. The posterior surface has a larger lateral part and a smaller medial part separated by a ridge. The most medial part of the articular area may be recognizable as a separate area. This part articulates with the medial condyle of the femur only in extreme flexion of the knee joint. So basically in normal bone, the medial condyle will articulate with the posterior medial surface of the patella. Okay. But in extreme flexion, the medial most part also gets involved. So this part initially in a normal leg, it will not get involved, this part. But in extreme flexion to you know na. So if this is bending of the knee, suppose this is bending of the knee, this is extreme flexion. Okay, this is extreme flexion. I mean straightening of the leg. The most medial part of the articular area may be recognizable as a separate area. This part articulates in extreme flexion of the knee joint. Articulates with the medial condyle of the femur only in extreme flexion of the knee joint. The lower part of the posterior surface is non-articular again. So this is the lower part of the posterior surface. Here some other structures actually originates. For example, ligamentum patella. See, it is rough for attachment of the ligamentum patella. This is not a muscle, this is a ligament. So now coming to the attachments of the patella. So basically it has a superior border, medial margin, lateral margin and an apex. So there are muscle origins for muscle insertion for two muscles. One is rectus femoris, another one is vastus intermedius. Okay. So how many vastus are there? 3. Vastus intermedius, another 2 are medialis. Okay. So you will see in dissection also. In the medial margin, we have one retinaculum, that is medial patellar retinaculum. So what is retinaculum? Retinaculum, flexor retinaculum, extensor retinaculum. So what is retinaculum? Modified deep fascia. So you will see that the deep fascia is almost in approximation with the muscles in a body, but in the flexor retinaculum part you will see that the fascia gets thickened. So this is a modification so that the structures can easily pass through them or over them. So in the medial margin, the medial patellar retinaculum attaches, which is an expansion from the tendons of vastus medialis muscle, and lateral margin, lateral patellar retinaculum, expansion from the tendon of vastus lateralis. So basically if this is the patella, so we will see in another picture. Okay, there is no picture. So basically if this is the patella and here the vastus, first the vastus medialis attaches and vastus intermedius attaches and the rectus femoris attaches in this part, and on the medial side we have here the vastus medialis present. So the ligament retinaculum or the deep fascia comes downwards, crossing the muscle, and here the medial retinaculum forms. Okay, medial patellar retinaculum forms, and similarly in the lateral margin, lateral patellar retinaculum attaches here, and in the lower part this is non-articular, this part is non-articular, but in the anterior surface lower part, here there is articulation for ligamentum patellae in the exactly at the anterior portion, but the posterior part, here there is no attachment as such. Okay, so this is basically in the anterior portion the ligamentum patella attaches, almost in some cases anterior, in some cases posterior, but mostly anteriorly. So basically the patella ossifies from multiple centers in between 3rd and 6th years of life. Okay, so it is nothing such as primary center or secondary center. All the centers, like there are multiple centers and all of them fuse together to form the patella. For this reason, like, I mean, any anomaly occur in patella. Do you know about any anomaly? What is bipartite patella? So what do you mean by bipartite? Two parts. Bipartite means two parts. In some children or patients, you will see that if you do the X-ray, obviously they will have some problem. If you do the X-ray, you will see that there are two patellas. I mean, this large piece, and suppose this smaller part is not present in the patella, it is broken out. So you will think that the patella is broken, but it is not the case. It is actually bipartite patella. So basically, most of the centers have fused together, but one center is left behind, which haven't fused with the rest of the patella. So it becomes a detached bone. So that is bipartite patella. Now coming to some clinical anatomy part. Transverse patellar fracture. So if a patella undergoes fracture, suppose transverse, in a transverse fashion, so this is transverse fracture. If a fracture occurs like this, so what will happen to the upper part and what will happen to the lower part? See, in the lower part there is only ligamentum patella. Okay, but in the upper part, what is there? Attachment for what muscle? Quadriceps femoris. So if this part detaches out, what the quadriceps muscle will do to this part? It will pull it. So the patella will, pull upwards. It will come in the thigh, almost in the thigh. Okay, the lower part will be there only. Ligamentum patella is not that strong, but the muscle will pull it out, and the upper part will pull upwards, will be pulled upwards. That is transverse patellar fracture. So this is the real fracture actually. But in case of bipartite patella, it will be only two bones. What is housemaid's knee or P-patellar bursitis? What do you mean by bursa? Bursa means fluid filled sac. So a bag with fluid, simple thing. So the bursa prevents any friction between bones. Okay. So pre-patellar bursitis. What do you mean by pre-patellar? Pre-patellar means in front of the patella. So in front of the patella there is a bursa. So what happens in case of housemaid's knee? Forward and like swipe the floors. Okay. So due to this reason the bursa gets inflamed. Okay. And due to this inflammation, bursitis occurs. You will see that patients coming with complaints. This is not only the case with housemaids also. If you also like continuously wash your floor regularly, kneeling down, you will also see that over the years the knee will get swollen. This is bursitis, pre-patellar bursitis. It occurs commonly in housemaids. Now what is clergyman's knee? So basically subcutaneous infrapatellar bursitis. So clergyman's knee occurs infrapatellar region, in the infrapatellar region. So just below the patella. So in the infrapatellar region there is infrapatellar bursa. This undergoes inflammation, bursitis. Okay. So this occurs in clergyman's knee. What do you mean by clergyman? Tell. So in certain religion there are some traditions where they kneel down and pray to God. Okay. In those people, so clergyman's knee appear. If you see that in case of so what is the difference between housemaid's knee and clergyman's knee? In housemaids they usually kneel forward and wash the floors. Okay. That is why the pre-patellar bursa gets inflamed. But in case of clergyman's knee, they don't kneel forward. They just kneel down. They don't bend forward. Okay. due to this region only the infrapatellar bursa undergoes bursitis. So that is all in patella.